Well, welcome back, everybody. We appreciate you hanging on with us so far today. We know we've covered 3 sessions and a good bit of content. So just thank you so much for staying with us. We want to conclude today's session with our fourth and final question that we're going to address, and that is, how can hospitals prepare for the future? So, so far we've really been looking at how hospitals have been complying with this information, what information is available, how we try to defend our position. And now we kind of want to turn to the last piece in all of this puzzle. And that's really, what's next? How do we take next steps in all of this? And so with that, we're going to be kind of walking through some of the elements that we think are important for you to consider as you navigate next steps in your strategy development. When we think about kind of the first sort of landing spot is evaluating your current position. And some key questions that you could ask yourself are, are you comfortable with your current disclosure position? We've gone through a lot of information today in terms of what others are doing. Based on that display of information, does it impact how you think you want to be presenting your own information? We've talked about the potential for enforcement now. And so does that factor now come into your thought process in terms of how you might want to disclose information? How does this information compare with your peers? And really to kind of get at some of this, we have developed a kind of a reference tool, and we'll provide this for you at the conclusion of today as well. A lot of our kind of clients have asked, gosh, is there anything that we can do to kind of document this process as we're reviewing this information for our peers? And so we've put together a fact-finding report that you can use to be able to document the date at which you went in and found the file, the link to the file that you found. Again, we've recognized that sometimes the navigation and finding this can be a little bit of a challenge. So putting that into the file is useful. And then going through and sort of just documenting what information is available. This all really ties back to the checklist that CMS put forward. And there's a link there on there for kind of their quick reference checklist for the elements that are required in the rule. This more simplified checklist that CMS has put forward, we believe probably will be the basis for any type of audit or review that they would have. So whether you look at that link or you take kind of the fact-finding report that we put together, which again is based on that link, might be really useful for you to do for your own position, but then also kind of looking at how your peers are providing information as well. The next step is trying to then compare where possible. So with the disclosure of this information, are there opportunities for you to be able to take your data and compare that against your peers? You can look at the gross charge variation that exists. We recognize that, again, about 85% of the folks that we're looking at are providing that level of detail. And so gross charge information, certainly those that have a HCPCS kind of tie-in provide more ability to create some comparisons there. As you get into the payer information, do you see internal payer differences? So this would be kind of your Aetna to your Blue Cross. This can be really useful as you start to try to determine, as you put your file out there, will somebody have a Wall Street Journal article and say, hey, look at the variation between a C-section. So getting out in front of some of this information so that you're prepared to address any questions that might result from your own disclosure. And then do you have significant external payer variation? So this would be your Aetna to a peer's Aetna value. Are you able to make some of those links? Of course, we talked about the challenges that can exist there, but we did also talk about some of the opportunity if you do have kind of a standardized approach to presenting this information. So again, if you're presenting in a DRG fashion, and your peers presenting in a DRG fashion, it gives you the ability to sort of drop in your data and to create some links there for how you compare to your peers and how you compare kind of regionally and nationally as well. So all of these things can be very valuable in terms of helping us understand what variation we might have and understanding kind of how that compares to our peers. With that, then we tend to sort of get into this discussion of, okay, if I know the variation is out there, is there a way to mitigate that variation? Can I look at these gross charge differences? Can I look at these payment differences? And am I able to sort of mitigate some of that to kind of narrow or to close that gap? And to discuss how to close that gap, I'm going to invite Chris Blissmer to come in and actually share how we can approach those types of questions. Chris has been intricately involved in working through some collaborative solutions on this regard. And so we'll have Chris present some considerations and potentially some best practices for you to consider.
Thanks, Jamie. My name is Chris Blissmer. I'm a senior strategic advisor with Cleverley and Associates, and I'll be speaking about addressing the variances that we are seeing in transparency data analysis. This can seem like a fairly complex process. We've laid out 4 key actions to help guide us through this process, starting with minimizing gross charge variances through CDM adjustments, looking at key drivers for payer variances, whether they're the underlying rates or terms you see in your contracts, or the variances might be driven by acuity or utilization differences. We'll also look at layering in cost or margin information, additional kind of beyond transparency information that's helpful in making decisions when looking at variances. We're also going to talk about testing the impact of gross charge changes or payer term changes as we look at minimizing the variances we've seen in the data. The first step when we're looking at minimizing variances, minimizing gross charge variances specifically, is to translate the variances we're seeing in the transparency data to our charge masters. So here we have an example of 3 different types of charge variances, 2 encounter level, DRG and APC, 1 code level. The code level example is the most straightforward, which would be the easiest to translate to your charge master, although you may still have several codes utilizing the same CPT code. The encounter level comparisons are a little trickier and will often include several codes. So our 470 DRG example, when we're looking at a major hip knee replacement, you'll involve surgery, anesthesia, supplies, various ancillary services that could impact that overall charge. So an understanding of those key items within your charge master that can drive the charge variances will be key to testing and understanding the impact of addressing the variance. One of the other key important things to consider is utilization or acuity, especially when we're looking at encounter level data. The example that we're using here is, again, the DRG 470, a fairly common DRG. We're looking at, in the top, our case hospital has a $70,000 average charge compared to their peer of $62,800. Does that mean we should immediately reduce our charges in the underlying charge master lines? Maybe not. Cleverley and Associates will utilize Medicare all payer data essentially to look for additional information to try to understand if there are utilization or acuity differences. So on the inpatient side, which we're seeing an example of, we can see length of stay, the use of routine versus ICU, the occurrence of secondary procedures. On the outpatient side, when we're typically expecting an APC comparison, the utilization of procedures or the average relative weight per visit will often help us understand if the charge variance is driven by acuity or utilization beyond just the charges we see in the charge master. In this example, the length of stay values are very close, 2.1 to 2.3, but the use of the secondary diagnosis may tell us that the case hospital cases are a little more complex, and there might be additional ancillary charges driving some of that charge variance. Likely, in this case, with the length of stay that's very similar, knowing that the implant and the surgical charges are going to likely drive the majority of our charges, we're looking at a legitimate variance, having corroborated with our additional data. Whenever we make a change, we're going to want to test the impact, whether it's a gross charge change in our charge master or what we'll address in a few moments when we're looking at term changes within our payers. We certainly want to understand the gross and the net impact of our potential changes. So the visualization on the slide is an example of the impact of our examples, reducing charges in line items through CT adjustments. Our DRG 470 has been grouped with a series of item codes that are associated with that. The top example is looking at just a straight charge reduction. The bottom example is showing an offset, where we're looking at increasing charges elsewhere to offset that loss. So how do you get an accurate assessment? You certainly want to include all of your payer-specific terms. You need to understand your rate increase limits, lesser of clauses, outliers. That information needs to be part of the test. The timing of rate increases is something to consider. If you've already had an annual rate increase and disclosed what your annual rate increase will be to your payers, if you're going to change that, you certainly would want to consider the impact of providing that information to payers if you have a significant change. Often, when you're looking at significant changes in your charge master, you would like to consider coordinating that with your annual rate increase. That will often give you much more flexibility in testing or implementing CDM price variances, and you might be able to tackle several variances at the same time in conjunction with your annual rate increase. The last point is something certainly important to consider for your charge master integrity. When you're looking at changing prices in your charge master, you have to consider charge master families. Certain groups of codes, like our visit levels, CT MRI without contrast, and then procedure families, are essentially based on a level or the length of a procedure. Those have relationships. If you address only one code, there's a good chance you might break those relationships. So as you do CDM assessments and looking at making adjustments for gross charge variances, you certainly want to bring those whole families in for that assessment. One of the additional pieces to consider, which is somewhat we feel outside of transparency, are our non-hospital competitors. The transparency disclosures that we're reviewing are hospital-based, and the variances we are now focusing on are variances to our external hospital peers. But we know we're also competing with freestanding facilities. Imaging, lab, surgery, therapy are the top areas, and they present an additional level of challenge to hospital pricing. As you work through looking at variances and how your position lines up with your hospital peers, don't forget the freestanding facilities. Obviously, hospitals that are in direct competition with freestanding centers know this very well, that the price points can be much lower, and they will certainly have a lower payment per case rate in many cases. So you may want to consider, just as you're doing now when you're looking at imaging, lab therapy, that you're automatically bringing in that freestanding information as you look at your variances. We're going to shift a little bit. We're talking about gross charge impact, gross charge variances, and minimizing those through charge changes in the charge master. We want to shift gears a little bit into payment and thinking about the considerations, questions as you evaluate your payment differences and some of the same acuity and utilization issues you may want to consider before taking action. Probably the biggest interest of transparency information is the comparability of payment between hospitals with for the same payers. I think we've explored a little bit in the previous sessions that there's certainly going to be some challenges with aligning this and putting this together cleanly, but certainly wherever we see that payment information, it can help with our analysis in identifying variances and then what actions we may need to take to mitigate those variances. In this case, we're again looking at 3 examples of payment variances at a code level, a DRG level, and an APC level. And let's think about some of the questions that we have when we're looking at these variances. So are your external variances likely to create upward or downward pressure? Essentially thinking about payer negotiations. Are we likely to see those variances driving those negotiations, whether they're opportunities or risks? We certainly want to evaluate which variances are meaningful to us that we may need to address, whether they will impact contract negotiations or have an opportunity for the hospitals to bring those to the table in negotiations. When you're thinking about the external variances, you're always thinking about the underlying term, what's creating that payment. Are payments based on a percent of charge? So is there a charge-based link to the payment that we're seeing? Kind of the typical percent of charge contract that you will still see. In other cases, the payment could be a per diem or a fixed rate, a case rate, or set up on like a DRG payment where there's a base rate times a weight. Utilization can play a key role in what those payment rates are. Is there a major market player that would have the negotiation clout to have the higher rates? Do rates follow the understanding of the utilization in the market? You will certainly have more information on your internal variances. So are your internal variances caused by acuity, utilization, or your underlying contract terms? Are good questions to start with as you're analyzing your variances. We're going to walk through a case example, starting with an internal variance and then layering in some of the transparency data you may be able to pull together in your particular market. In this case, we're looking at our DRG 470 case. 2 specific significant payers, Blue Cross and UHC. And we see an interesting dynamic here where UHC has significantly more charges or utilization volume in DRG 470 than Blue Cross, but their per case payment is much higher. You see a $36,000 per case payment compared to $28,700. Typically, utilization could drive a lower payment. So we're seeing that an opposite in this example. When we look kind of behind the scenes of what's driving payment, in this case, we're seeing Blue Cross pay on a case rate while UHC is paying on a standard base rate times a DRG weight. Does the lower utilization from Blue Cross support a push for a higher case rate in negotiation? Is there a risk that UHC is going to come to the table to push for a lower payment if they're seeing this type of information? As we add in transparency data that may be available, it can help us understand how we line up to our peer market and whether the anticipated action, either from payers or how we would like to react to those, is supported. So in this case, we're looking at bringing in the national median charge per discharge and payment per discharge for Blue Cross and UHC. We see the charge information is very supportive of where our case hospital is today. The national median charge in Blue Cross looks a little bit higher, but they are very close together. looking at the payment variation, which is part of what caught our eye in this case, the lower Blue Cross payment, the national data supports what we're seeing, but it certainly shows that lower Blue Cross payment is lower than the national average, and maybe an opportunity for us to either address it through contract negotiation or leverage that in other service lines where we may still impact net. We can also, as we see on the bottom, layer in our own internal cost information to help us understand what our costs are and what our margins look like on particular product lines. Understanding costs will certainly help strengthen negotiation with payers, especially when we're looking at close to margin lines and pushing for higher rates. The last case, or the last bullet point we're going to move into is back into what we've talked about briefly, which is testing. Whenever we're looking at changing our managed care payer terms, looking at changing our charge master prices, we certainly want to complete a test to understand both the gross and the net impact. This slide is looking at some of the components within those rate tests. When we're looking at changing a term or understanding the impact of a term change, when that is done in conjunction with charge master prices, we certainly want to incorporate that full test. We see all payer terms included, including your outliers, lesser ofs, rate increase limits. All of that could have a significant impact on the result of the test. This is looking at an example result of a test specifically looking at one payer where we've reduced charge master prices in cases, codes that are associated with DRG 470, but also looked at the impact of negotiating a slightly increased case rate, best of both worlds, and as an example. If you are trying to incorporate a significant amount of change in your charge master, certainly as we pointed to, the timing of the rate change may best be done in conjunction with your annual rate increase. When you're looking at changing specific terms with your payers, that often is off cycle and specific with that individual payer. Certainly putting a plan together or a strategy to understand what areas of your contract are on the table for mitigation will allow you to do a more thorough micro and macro evaluation of that net revenue impact, and certainly take that service line's review out across all payers. So you're understanding the impact across all payers and where a particular payer's rates line up. So addressing variation and transparency is going to involve both charge master changes to your CDM, as well as potentially negotiation of term changes. Following these key actions will help keep efforts focused on your meaningful variances and increase the likelihood of a successful outcome. Some of the variances you'll see certainly weren't developed overnight. We've had a long history of rate changes and contract negotiations, and this data is new. So likely we're not going to be able to unwind some of those very quickly, and it may take a multi-year approach. Developing a team, including managed care, your charge master pricing team, and your finance team, to understand, identify, and address these variances will be best practice. It will be a multidisciplinary approach. Leadership support is a must for the organizational change for it to happen. Thanks everyone for the time today. I always enjoy talking about hospital data. I'm going to turn the session back over to Jamie Cleverley now to wrap up our final thoughts on the session. Thank you.
Thanks, Chris. Appreciate you walking us through how we can take a look at these variances that exist in the transparency data and begin to create some mitigation strategies to help walk us to a place that we might feel more comfortable and confident with going forward. We want to conclude not only today's session, but also our summit with one prevailing thought, and that is the final step, or potentially the first step in all of this. And for that, we really come back to this center point of helping patients. And let's let that sink in for just a second. This thought is very powerful for us to consider in light of all that we've talked about, because it's the reason why the rule was developed in the first place. And it's, I think, very easy for us in the industry to look at the complexities, the challenges that exist in the assembly of this data and the disclosure of this data, and look and doubt how useful it will be to the patient. Again, we deal with this stuff day in and day out, and we recognize how much of a challenge it is to communicate this information clearly and to make it very user-friendly to our patients. And yet, again, that's where all of this really began. And so it's helpful for us, I think, as we're beginning to look at our strategy, to look here and say, how user-friendly is our information? How accessible am I making some of this to a patient that might be confused at trying to understand his or her financial obligations with regard to their encounter of care? So we kind of leave with a little bit of language that I think is really interesting to sort of paint some context here. We talked at the outset of our day about this timeline, and we're going to zero in on one specific time period, and that was the initiation of ACA to that very first point at which requirements came out specifying exactly how CMS wanted to see our data presented. So ACA started, and it was essentially an encouragement to provide this transparency information to patients. And it went some years where there was silence. CMS really didn't even make a comment around how we were supposed to do this, what it was supposed to look like. And so with that, many of us looked and said, okay, I know this sort of requirement is out there, but it's really ambiguous. I'm not quite sure how to take action on any of it. And so it kind of sat. We got a reminder in 2014, and there's a line that is highlighted there at the bottom. And let's look at that together. It says, we believe, this is CMS, we believe hospitals are in the best position to determine the exact manner and method by which to make the list public in accordance with the guidelines. They're essentially giving hospitals the leeway of how to display this charge information. And again, we went 4 years before there was any additional guidance. And I have to sort of get a little bit introspective here and think if we as an industry would have been more proactive in really making this information more accessible, more meaningful, and more usable to patients, that we might not be in the situation where we're at today, looking at a litany of requirements that also include now civil monetary penalties if we don't comply. And I say that not to sort of be a slap on the wrist for any of us. I think when we look back historically, without clear guidance on what we were supposed to do, it was very challenging to look and say, well, what is compliance, and how do we advance some of this? But we're now in a different spot, and we now know what the requirements are, and we have, I would suggest, maybe an opportunity in front of us to take these requirements, to look at how we comply in the best possible way because there is still some flexibility in terms of how we present the information back. And to be able to use that as an opportunity to share this information in a more dynamic way and to reach out to our patients and to provide an opportunity for them to have access into this information for their betterment. And so I leave that as kind of both a closing thought and also potentially a challenge for all of us to continue to be forward thinking about this transparency topic, so that we don't just sort of try to check a box here on did we meet or did we not meet these requirements, but how are we including this patient experience and this patient perspective into the continued development and engagement with our community around this piece. I think if we can do that, we really have an ability to change the trajectory of this timeline to show how hospitals and patients have come together collaboratively to create really neat solutions to present this information to them, to help them make informed decisions. So we recognize that your investment of time today speaks to your commitment to doing this. And we cannot thank you for making an investment of time to do that. And we want to offer the opportunity for us to support you in whatever way we can to make this easier and more attainable for you as you move forward with your strategy development. So thank you so much for your commitment. Thank you so much for making your patients such a critical priority and for navigating this very, very difficult environment and making this information usable and meaningful to patients. So we conclude today by a couple housekeeping items, and to let you know that we will be making this content available on our website. So if you'd like to revisit any of it, if you'd like to share it with others, we will be making this content available. We'll also be taking the questions that you've posed during the day. And again, we appreciate your feedback throughout these sessions. We'll be taking those questions. We'll be providing answers to the entire group so that you can kind of see collaboratively what other organizations and individuals have been commenting on and how those questions can be addressed. So again, thank you so much for making time today. We appreciate it sincerely, and we look forward to continued conversation with you in the days and weeks ahead. Have a great rest of your day.